As I said, she's from Hight-Up. You have the very much interest in data science, as I have seen in your bio, and the rest of your bio CV. Please introduce yourself.
Do you have my CV? So it's a bit cold up here.
Yes.
So, good evening, everyone. My name is Picharee Karunayawong. That's how my name pronounced. And I'm a researcher at Health Intervention Technology Assessment Program, or HITAP. And today I'm going to talking to you about the Hight-Cost user in Thailand. Yes, I'm not opening the wrong slide. This is what I'm preparing for today. Okay. So, you are all invited to my party, and please sit tight and grab some free donuts. So I would say imaginary one. I don't have it all today. And so imagine if you are all to join this party and the music is really good and you're dancing really hard and until you're feeling hungry and you need some donuts to soothe your calling stomach. So, but somehow half of it is gone. Half of the donuts is gone now. So how would you feel? Still hungry? Sad? Upset? Or feeling this world isn't fair? Why? The one who get to eat is like him. Because him here, he got to eat the donuts. So this world isn't fair. Why Mr. Simpson got to eat almost of the donuts? So if this is not a real party, if this is the healthcare system where the donuts are healthcare expenditure, and everyone in this party, including you, are the patient who really need the care from the system. Here. So this phenomenon is actually happening in the real world. It is called the high-cost user phenomenon. So what is it? So the high-cost user phenomenon is the situation where the healthcare spending is often concentrated in a small proportion of our population. And from the existing literature, this situation is actually happening in many countries around the world, such as Japan, United States, Norway, Italy, Australia, Canada, and including Thailand too. So you might wondering that there is already existing literature that Thailand is facing this problem and why I'm still standing here talking about this again. So the first thing is that the COVID-19 pandemic came, and we all know that during the pandemic, the resource is limited, and the healthcare resource is limited, and the hospital is not where that you can go whenever you want at like the same. And so you might want to know, during the pandemic, does this high-cost phenomenon still continue? Because we all know that high-cost user consume a lot of healthcare expenditure and healthcare resource. So if this is the case, if this phenomenon still exists, we might understand this phenomenon. It might somehow help us to understand like where the resource has been utilized, and then we could learn from it and utilize it more efficiently, and then can reduce the burden of our healthcare system. So another thing is this study is also an example of using real-world data to answer the policy-relevant questions. So, sorry. The objective for this study, we have 5 objectives that we hope to learn from this study. So the first one is, does high-cost users still exist during the pandemic? And the second is, who are they and what are their characteristics? And the next one is, what are the top 5 diagnosis of the high-cost users? And the fourth one is, what are the predictors of the high-cost users? And does all of this change apart from the pre-pandemic period? So, for the methodology, this study is a secondary data analysis, and we acquire the data from the National Health Security Office e-claim hospitalization database, and we use the inpatient under the Universal Coverage Scheme as our population, and our data is covering from January 2016 to December 2020. For our variables, we include total cost, health expenditure, age, sex, diagnosis, it will be the ICD-10 code and the hospital type. The major outcome will be health expenditure and the risk factors. And we use 2 types of analysis, which is the first one is the descriptive analysis that we use for most of the part of our study. And we also use multi-variable logistic regression to find what is the predictor of high-cost user. So what did we found? First, we found that during the pandemic, the high-cost users still exist in Thailand. So if you look at the stack bar graph on the left, the top 2 one, the yellow and the light blue blocks of each bar graph, they denote 5% of our Thai population, and which that 2 blocks account about 50% of our healthcare expenditure. And you can see that the proportion is even getting bigger during the pandemic. So next, we found that the characteristics of high-cost user remain relatively the same from the pre-pandemic to the pandemic period. So if we look at the proportion between female and male, we see that high-cost user is about 45% to 55% in both periods, and the average age is like 54 to 56 in the pre-pandemic and increased to 57 in the pandemic. And the average length of stay is 7 days per visit. It's the same in both periods, and the average number of visits is 3 times per patient per year in both periods too. And the average cost per patient in the pre-pandemic is about 122 to 120,000, and in the pandemic is about 124,000. So next, we use the ICD-10 code to run through the primary and secondary diagnosis group to find that which diagnosis that high-cost user mostly endure. So the first one is hypertension, and the second one is the non-metastatic solid cancer, and the third one is diabetes without chronic complication. The fourth one is chronic renal failure, and the fifth one is myocardial infarction. So lastly, as I say, I used multi-variable logistic regression to find the factor associated with who are more likely to become an high-cost user. And I found that patients with who had a circulatory disease as a primary diagnosis, and people who admitted to community health center, and people who were discharged with the disease status, and people who had high number of visits per year, and who had higher comorbidity are more likely to become a high-cost user. So in conclusion, we found that high-cost users are accounted for almost 50% of healthcare expenditure in Thailand. And during the pandemic, high-cost users still access to the healthcare system. And the characteristics of it and the top 5 diagnoses are relatively the same in both periods. It doesn't change. So what next? What could we do from our work? That's a really important question, right? So by understanding the high-cost user phenomenon, policymakers could come up with plans or measures to help utilize the healthcare spending more efficiently. For example, now we know which group of disease that already have like high-cost user who consume the majority of the budget, the healthcare spending. So we can use that as like a prioritization. We can prioritize which disease that we can pick up and to kind of create the prevention measures. So not many patients come into hospital with that disease. So we can help the system to utilize more resource, healthcare resource and healthcare budget more efficiently. So, and in the future, because we have the issue about data limitation, our information is not that much detailed. So we hope that deeper analysis could have been done, such as the core course and the structure of the healthcare spending analysis, and personal level data in high-cost users, such as we can do like chart review, so we can dig in more detail, like how they become a high-cost user, what are the source of the problem. And, oops, sorry. So I just hope that this study sparks and support the evidence and support the effort toward the healthcare spending and healthcare budget utilization, so we can have more healthcare budget and healthcare resource to like distribute more equally to other who really needs them. And thank you.
Perfect timing. Thanks a lot. I've never seen that somebody was so perfect in time. So, first of all, now the questions from the commentator, please.
Yeah, thanks for the wonderful presentation. I think it's good that you start with a funny way of approaching this topic, but to illustrate the importance of this finite healthcare resource. I have a couple of questions. Maybe you can help me clarify.
Yes.
I think in the results, it shows that the top 5% accounted for 42% of healthcare costs in 2019, but this increased to 45%. I thought probably it would be good to show in terms of the absolute value, what is that change instead of stacking everything to 100%. And then that would actually show really what is if there's a significant increase, and is it whether caused by the COVID and its management of the complications. And that leads to my second question, whether you have done analysis on what is the impact of this COVID and management of its hospitalization orders.
So thank you for your suggestion. So it is nice. So I will take that into account, that if I were to proceed this research in the future, I may use the absolute value to show that the significant change. And for the second question, the COVID. So apparently, me and my team didn't use the COVID pandemic as one variable in our study. But then I think what can be expected that the majority of costs will be caused from the COVID-19. That's what me and my team are expecting, but then we didn't take that into account of our recent study. Did I answer your questions?
I just have one bit more basic question on what is the definition of high cost user? What is the criteria for chosen this is a high cost user? Like when you say maybe like eating 10 donuts out of the box, what is the definition of HCU?
So can I? Okay, party. Let's go to a party. So I think there's no exactly the number or the criteria of what define the high cost user, but it's just like a phenomenon. It's just like a subjective. It's just called the situation of phenomenon that, the healthcare spending is concentrated in a small proportion of the population, but it didn't have like how small it is. Like that's it, your question, right? But then I think I didn't find any of it, like how small does it define to be the high cost user.
And will your analysis lead to finding solution of how to reduce the cost among these users?
So this is just like a starting point. Like I say, I just hope that this work like helps sparking and the more study toward like after this the further analysis. So as I say that that is like our limitation of my study, that the information is really limited. So we didn't know so as I mentioned that more of cost analysis, cost structure, and the personal level analysis should be considered in the future study to get to know who are the really cause of this high cost user phenomenon. It's just like a starting point.
Okay, thank you. Now it's up to you. You can also put some questions here. Please stand up and.
So anyone want to join the party?
There's somebody's moving. Yeah.
I just wondering if you consider based on the same patients and period before and during COVID-19 situation, and then compare the cost now within the same person, whether the cost increasing or decreasing.
So the way how we did this study is like, so it been separate each year, and you kind of generate a unique ID of each patient. So, and we then stack it up, and we look at the top 5% of the patient who like the top 5% like, and look for the proportion like how much they use the healthcare spending. Yes, that's how we do. That's how we stack out our patient. But then we didn't track them through each year. Yeah.
Thank you.
Can I track them? I think yes. We do have the patient ID, so it's yes.
So I like to share, I think that the first question responding to Dr. Pan is that one way that we could identify the definition of the high-cost user is that we can collect the data, analyze the data on their cost or on their expenditure, and then we can classify as a top 5 percentile of their cost. And I think to Dr. Amarin and Dr. Yot's question, I think because we have like the 5-year database, and another way what maybe Picharee didn't report on this meeting is that we try to identify the existing high-cost user in like at least 3 years. So I think this is one of the results that will be included in her research study.
Thank you.
Hi. So thank you, Picharee. Very, very good presentation. So I think also, 'cause I think we said 5 percentile. Some country, they may actually found that only 1 percentile of the population may be using the majority of healthcare costs. So I think that's something that's why in terms of the criteria, we want to, in the literature at least, they want to make it a little bit more subjective. And listening to Dr. Amarin and Dr. Yot and Ms. Varanya point, I think that could be something we could explore in terms of track people utilization over time before after COVID. Certainly, it will answer a different question, but one assumption, and it is, as we all know, when you work with real world data, it depends on the data. So the person, as a starting point, we can only track people who actually have any hospitalization. So if people don't have hospitalization or they only have it in 1 year, we won't be able to track them. So our population may shrink, and it will focus only on people who have repeated hospitalization over time. But we can group them to say before COVID and then during the year with COVID. So right now we have the year 2020 and 2021. So if they do have more than one hospitalization overdose, then that is a new question. So Picharee, this may be the next paper as well. Thank you. Back to you, Peter.
That's my boss.
Yeah, and also for the party team, you have the party shirts on.
Yeah,
and
yeah, my team. Thank you, my team.
Yeah? Okay, more questions? More people who would like to defend?
I
Okay.
need to protect myself.
I believe so, no doubt. Thank you for this presentation.
Thank you.
For letting us have
Hope
part in
everyone
this party.
enjoyed it.
Yeah?